All right. Yeah. So today I'm going to be talking about, my name is Rebecca, and today I'm going to be talking about protecting the health of older adults during wildfire events, a background and rationale for indoor air quality interventions. So what I'm really going to be talking about is some previous studies that kind of frame my dissertation, and then at the very end, I'll get into my tentative aims. So the main problem that I'm looking at is wildfires and wildfire smoke. High elevation Rocky Mountain forests are burning more than any point in the past 2,000 years. So there's a lot more wildfires. And smoke from these fires travels and engulfs residents of nearby states, including Montana. Sometimes there's fires in Montana's, but fires also come from Canada, Washington, Oregon. We saw last week it was pretty smoky. So wildfire smoke is a problem here in Montana. Wildfire smoke has a few components, including organic gases. These are called volatile organic compounds, metals, PM2.5, PM10, and other products of combustion that aren't really relevant for the sake of this presentation. PM2.5 and PM10 are small. So if this was the size of a human hair, these blue dots would be the size of PM10, and these pink dots would be the size of PM2.5. So PM2.5 is pretty small when you're looking at that compared to a human hair. For this presentation, I'm really going to be talking about PM2.5 and its health risks because it's a main component of wildfire smoke, and we know that it causes health problems. PM2.5 are fine inhalable particles made up of a mixture of solid particles and liquid droplets. They're small enough to enter the lungs, the bloodstream, and cause or worsen heart and lung diseases. In 2010, wildfires contributed less than 20% of the total ambient PM2.5 in Western regions. So 15 years ago, less than 20% of PM2.5 was coming from wildfires. But as of 2020, wildfires contributed to up to 50% of the total PM in Western regions. So we're seeing a lot more PM specifically from wildfire smoke in the Western United States. A study from 2018 found that PM2.5 was generally decreasing in all areas of the United States except wildfire-prone areas. This is because of technological advances and policy changes that made it possible to decrease PM in other areas of the country, but in areas where we have a lot of wildfires, like right here in Missoula, we are seeing that PM is not decreasing. A model that was done in 2020 looked backwards at PM, and they modeled how much of that PM came specifically from wildfire smoke. And they found that from 2006 to 2008, yellow being the most PM from wildfire smoke, there really wasn't that much compared to 2016 to 2018, where this western area of the United States has a lot more wild PM from wildfire smoke compared to 2006 to 2008. Looking forward even more, another model projected that the average wildfire specific PM 2.5 level could increase an additional 160% by 2046. So we can see that PM from wildfires is increasing, and we project that it will continue to increase throughout the century. Does PM 2.5 exposure negatively impact human health? And the answer is yes. And it does this a couple of different ways. So, like I said before, PM 2.5 are small. So they're small enough to get into the smaller parts of the lungs, like the bronchioles and the alveoli. And from there, they can do different things in the body. It can move from lungs to your bloodstream, lungs to your nervous system, and then lungs to your system overall. When it goes from lungs to the bloodstream, this can cause vasoconstriction or your veins getting smaller, increased blood pressure, and evidence suggests that it can cause arteriosclerosis, platelet aggression, and more. And arteriosclerosis is when there's plaque in your veins, and that can lead to heart attacks. These PM2.5 can also move from your lungs to your nervous system, specifically activating the sympathetic nervous system or the fight or flight system. And this causes an imbalance. When you're anxious, you have higher blood pressure, your veins get smaller, and you have an increased heart rate. So PM is shown to do that, but it's also shown to do arrhythmia potential and decreased heart rate variability. Heart rate variability is a good thing. So decreased heart rate variability is negatively contributing to cardiovascular health. Another thing is PM can go from lungs and kind of throw your entire system out of whack. It can take you out of homeostasis. And it does this with systemic spillover or systemic oxidative stress, so your body's stressed for oxygen, and general inflammation. And this can cause vasoconstriction, arteriosclerosis progression, insulin resistance, contributing to diabetes, less high-density lipoprotein, or the good cholesterol, and more. So a lot of these are lungs. We know that it impacts the lungs, but a lot of these are also cardiovascular health. So PM 2.5 negatively impacts cardiovascular health through these three ways. A statement from the American Heart Association in 2010, they did a review of all the current evidence, and they concluded that the overall evidence is consistent with a causal relationship between PM 2.5 and cardiovascular morbidity and mortality. So PM 2.5 is causing cardiovascular health problems. Short term, PM 2.5 can trigger cardiovascular events in susceptible populations. So someone who is already at risk of having cardiovascular problems, these wildfire events can trigger additional problems. Long term, PM 2.5 has been shown to decrease life expectancy by a few years. Direct quote. I don't know how many years, but they said a few years. Older adults are uniquely susceptible to the negative consequences of PM 2.5 exposure, even if they are seemingly healthy. And they're susceptible because if you have an adult, a younger adult, and an older adult, and they're exposed to the exact same level of PM, older adults are more at risk of negative health consequences versus like a vulnerable population who are more at risk of more PM exposure. Long-term or short-term exposure to PM 2.5 and ozone in the Medicare population was associated with increased death, even when those PM 2.5 levels were currently below EPA standards. So it's currently below what we would flag, but it was still causing increased death in the Medicare population. Socioeconomic factors like annual income and having existing conditions like obesity or cardiovascular disease can further complicate this relationship or add increased risk on top of existing risk. In 2022, less than 5% of adults 60 and above had the American Heart Association standard of good cardiovascular health, which means that 95% of adults 60 and above were like more at risk of cardiovascular health problems simply because they didn't have good cardiovascular health. And then you add on all these other things, and that's why older adults are susceptible to PM 2.5. So you might think, okay, the air is really bad outside, I'll go inside. Even indoors, the presence of PM 2.5 can increase threefold during wildfire events. Remaining indoors, even with the windows closed, is not enough to protect against wildfire smoke. They did a study and they had people just go inside and close their windows, and it didn't help. Also, we know that indoor PM 2.5 is higher in houses and in skilled nursing facilities during wildfires. So wildfires do raise the PM inside. So what do we do about it? We start to think of public health interventions. And one intervention that's kind of been a hot topic is air cleaners. These are also known as air filters or HEPAs. They're the portable things that you put in your house and they filter out the PM 2.5. So this group of people in the field came together and wrote a commentary for an environmental health journal called Portable Air Cleaners Should Be at the Forefront of Public Health Response to Landscape Fire Smoke. And they had a few conclusions and recommendations. First, they said that many recommendations currently for air filtration come without guidance. So local or state health departments will say, when the air is bad outside, you should get an air filter. But they don't say how long to turn it on for, at what point you should turn it on, if your windows should be closed, what level to turn it on, because they come in low, medium, high, and turbo most of the time. So just very little guidance that come with the recommendation. Also, very little has been published on the considerations and challenges of implementing widespread filter use during smoke events, on actually making that happen. And there are a couple of barriers to doing this, like cost. These air filters do tend to be pretty pricey, and unpredictability of fires. We don't know exactly when fires are going to happen or where they're going to happen. So we couldn't even just have like a standby pile of air filters because we don't know where they would need to go when. So because fires are so unpredictable, that makes this more difficult. They also mentioned that we need air filters in private and public domains. So we need air filters in skilled nursing facilities, and we need them in houses, but we also need them in public places like libraries or doctors' offices. Finally, they mentioned that we should target air filter use first to susceptible subpopulations, like older adults. And then as the century goes on, we may need to eventually expand to the general public. But it makes sense to start with susceptible subpopulations make it work in those populations, and then we could expand later on. So air filters as a public health solution is necessary. I just spelled out all the health risks of PM 2.5, most important for susceptible populations like older adults, but we also have some evidence that they're feasible. So although more evidence is needed, several studies have demonstrated the feasibility of long-term air filter use during an entire wildfire season, in household settings, and in real-world scenarios, meaning that in scenarios where someone's allowed to leave their house, allowed to turn the filter on and off as needed, so that just really replicate normal human behavior rather than some trials that have them on all the time, or they don't want you to open your windows, stuff like that. The good news about using these air filters as an intervention is that where wildfire smoke sits, we probably can do some good. So what I mean by that is PM 2.5 has a logarithmic dose response scale, which means that as you're exposed to more PM 2.5, your health risk sharply increases and then kind of plateaus out. So for example's sake, these aren't exact numbers, but let's say someone that smoked cigarettes every day had an estimated daily dose of like 120. If we took that down by 20, their risk would not really change from here to here. They would still have high risk of health effects versus if we moved it. But where wildfires stand, they around here, not exactly, but if we moved your exposure down by 20, your risk would actually change quite a bit, just the way that this dose response works. So we can do good with these air filters because of where air quality sits, especially in Montana versus a developing country, and with the PM that you would get inside versus, say, like smoking cigarettes every day, it's at a level where we can likely do some good and really see some health changes by using air filters for this topic. So then the next question, and I looked at studies that tried to figure this out, are these air filters effective? And it really depends on how you're asking. They are effective at removing PM 2.5. So this study that looked at air filtration and then air filter effectiveness found that air filters can effectively reduce PM 2.5 during forest fires. And pretty much any study on this topic also finds that the filters reduce PM 2.5. So they are effective at doing that. But when you start looking at, are they effective at improving health, the answer gets a little bit more complicated, specifically cardiovascular health. So I was looking specifically at studies that were looking at wildfire-related PM 2.5, cardiovascular health outcomes, and older adults in air filters. And those were very limited. And by very limited, that means I couldn't find any. That doesn't mean that there aren't any. It's just when I was looking, and I was looking to find them, I couldn't find any. So they're very limited. But we do have studies that specifically look at wildfire-related PM, or studies that look at cardiovascular health outcomes and older adults. But they're maybe not looking at wildfires, they're looking at traffic-related air pollution. So here is an overview of some of the studies that are related to this question, but they're not quite hitting the whole question. And I have at the bottom, like these diagrams that show which parts of the question they answered. So most all of these studies are randomized control trial crossovers. This one's 2 days. So what that means is they had two groups of people. The first group got the filter for 2 days. They took a break, and then they got a placebo filter. So it looked and sounded the same, but it wasn't filtering, and vice versa for the other group. So each group had a placebo for 2 days and a filter for 2 days. And they were looking at if HEPAs improve cardiovascular health biomarkers in adults age 60 and older. And they found that there was an association, that it did improve cardiovascular health. They found that it improved most of the cardiovascular markers, except for oxidative stress, even with their short intervention. But this study had some gaps. It was not wildfire smoke related. It was short. They only had the filter for 2 days, and it was small. There were only 20 people involved. It was also outside of the United States, which isn't a study limitation, but it is a gap in that we don't know if it would be the same here in the Western United States, because it's pretty far away. Also, it wasn't a real world study. People were actually stuck in their rooms for the 2 days, and they couldn't open their windows. They couldn't move about. So it didn't really replicate how the world works day to day. Another study for the same length of time, same study design, in adults 60 to 75 that were looking at microvascular function also found that the HEPAs improved their outcomes. So it improved microvascular function by 8.1%. They also found that the smaller the particle was, the more beneficial the health effects were. They looked at PM2.5 versus PM10 and found that there were more health effects when they were looking at PM2.5. But gaps of this study are very similar. It was not related to wildfire smoke. It was short, only 2 days, and it was small. It was only in 21 people. So another study that was very similar, but for 3 days, also found the same thing. They were looking at HEPA filters in older adults. Their mean age was 67, and then the outcome was blood pressure. This study was a little bit different because it was actually in a low-income senior facility, which in this case was more like an assisted living facility rather than like a nursing facility in Chicago. And they found that the filters reduced PM2.5 and reduced systolic blood pressure. They also found that obese patients saw more benefit or better secondary and primary health outcomes than the people in the study who were not obese. The gaps of this is that it was not related to wildfire smoke. We're still looking at a really short trial, and they had 40 people, which is larger, but still small. So as the studies get longer, the next one's 2 weeks, we start to see the results kind of change. This one was looking at if HEPAs improve microvascular function and blood pressure in adults 51 to 81. And they found that there was no statistically significant effect overall. But they also mentioned usually these studies, all the ones that I've mentioned, found that the filters were improving PM. This one did not. Their filtration was variable. So for some people, it removed PM, but in some of them, it actually increased the PM in their homes. And it might not have increased the PM in their homes, but it just looked like the PM wasn't getting better. So that was a gap that they mentioned. This also wasn't related to wildfire smoke. It was slightly longer. It was 2 weeks, but it was still pretty short term. And they also said one of the reasons that they might have gotten these results is because they didn't have any filters in the bedroom. And the bedroom is where people sleep. So that's where they spend a lot of time. They only had them in the living room. Another study that was longer, 21 days, looked at these HEPAs, and they were looking at blood pressure and blood samples in non-smoking adults over the age of 40. They also did not find that the HEPAs improved this. After the air filtration, they said there was no reduction in blood biomarkers, and it actually appeared to increase blood pressure rather than decrease it as they would have expected. They had 20 people, so it was another small trial. They did not have a washout period, so they just went straight from filter to placebo or vice versa without time in between. Their study was not related to wildfire smoke or older adults, and they only had data on ultrafine, like less than 2.5 particles. They didn't know if the filters improved PM 2.5. They were only looking at ultrafine particles. The next study I found was 30 days, so we're starting to get longer. And this one was a pragmatic randomized crossover trial. So they really tried to let people open their windows or leave. They were trying to replicate real world a bit more with this one, also by doing it for longer. So they were looking at if these HEPA filters improve blood pressure, and then they also did some surveys asking how use was. And they did this in adults 30 plus. So for the participants with a starting systolic blood pressure of more than 120, which is a high blood pressure, filtration reduced that mean blood pressure by 3 compared to the placebo. But they found no clinically significant benefit in those who had a normal baseline systolic blood pressure. So it only had an association in people who had high blood pressure to begin with. Also, a portion of their study was on blood pressure medication. So the group that didn't have high blood pressure might have also been on medication, and that might be why they didn't see that change, because the medication was controlling the blood pressure to begin with. Their study was not related to wildfire smoke or older adults, and the filters were on 99% of the time. So even though people were allowed to leave and people were allowed to have their windows open, the filters were running all the time. It also was not a diverse sample. From the surveys, 2 people dropped out of the study because the filters were too loud and they had to be on 99% of the time. So it highlighted one potential, the opposite of benefit, one potential con of having these air filters is that it might be really loud for people. Another study that was for pretty much the same amount of time, 4 weeks, looked at HEPA filters and cardiovascular biomarkers in the elderly. Their mean was 66. And they had 2 people from each household, one with COPD and one without. And they also did not find an association. There were significant reductions of systemic inflammation biomarkers, but they did not observe improvements in cardiovascular functions. Some gaps of the study is that it was not related to wildfire smoke. It was longer, but still relatively short term. It wasn't in the US, and then their sample size was 35. The next one is a year, and this was the longest I was able to find. It's a relatively new study. It was published in 2024. And they did this for 1 year. It's different in that it wasn't a crossover trial. It was just, we give you a filter, and they randomized it, but they didn't have a placebo. And they looked at if the HEPA improved blood pressure and artery-related measures, like how much plaque was in the arteries or artery thickness in adults 70 and older. And they did find a positive association between the HEPA and these cardiovascular markers. So they found that there was improved diastolic blood pressure by 4.62. And they also found that there was improved systolic and pulse pressure, but not with statistical significance. So the only one that was statistically significant was the diastolic blood pressure. Some gaps of this trial is that it was not related to wildfire smoke. The N was 44, which is larger than the other ones, but still not like 10,000 people. It wasn't in the United States, and like this study a few slides back, the filter was only in the living room, not in the bedroom. So what does this all mean overall? Why am I sharing all of these? So zooming out a little bit, of the studies that I found and that I shared with you, the ones that were less than 1 month, 3 of them did find a positive association between using the HEPA and cardiovascular health, and 2 of them did not. For the longer term studies, 1 month or more, 1 found a positive association, 1 did not, and 1 had mixed results, meaning only the people with higher blood pressure found it. So regardless of time period, there's no consensus on if air filtration would improve cardiovascular health. With all of these filters, or all of these studies, we have these mixed results, and so we don't really know that this can improve cardiovascular health yet. We need more studies. Other gaps from the literature is, like I said before, studies looking specifically at older adults, wildfires, cardiovascular health are very limited. All these studies had components of that, but they weren't specifically looking at that. Many studies, while statistically strong, being a randomized control trial, did not factor in real-world scenarios, including human behavior. I have a filter in my house, and if I had it on high, which is what I would usually do if it was really smoky outside, I would not be able to watch a movie. So I would probably turn my filter off to watch a movie, which is an example of human behavior these filters could not really account for. Little research on older adults with existing cardiovascular conditions. There has been little research on older adults with existing cardiovascular conditions, in part because most of them are on cardiovascular related medications, which would make it really hard to see a result because the medication is stabilizing blood pressure and other things that we would measure. Another gap is that many of these studies are in single-family households. The reason why this is a gap is because we know that older adults don't only live in single-family households. We have some older adults living with family, like their children or grandchildren. And we also have congregate living for older adults, like assisted living facilities and skilled nursing facilities. So although we had that one study looking at a skilled nursing facility, there still isn't very much research about that context, that location, or how to put filters in those locations, because it would be a little more tricky than putting them in households. So my dissertation, these are 3 tentative aims that kind of take that background research and starts to fill the gaps. So the first one would be to test associations between air filter use and cardiovascular health among older adults in Montana using the American Heart Association's Life Essential 8 metrics. So, what that means is that in 2022, when they said that statistic that only 5% of older adults have good cardiovascular health, they also said, okay, that's a super low number. Why? How are we measuring it? And they came up with this Life's Essential 8 to show why that measure is so low and make it a little bit more attainable and really factor in holistic cardiovascular health care. So the Life's Essential 8 measures 8 things individually, and then it turns it into a composite score based on those 8 things. And it factors in diet, exercise, your blood sugar, weight, your cholesterol, blood pressure, if you're a smoker, and sleep. And then they also give recommendations. So all 8 of these things go into cardiovascular health. And it's also a measure on if someone has good cardiovascular health using all of these things. So more holistic. So what my aim would do is test if using an air filter in houses improved this Life's Essential 8 score. The next thing I would do is compare the associations between indoor PM 2.5 and the specific components of that AHA Life's Essential 8 metrics. So instead of does air filters change the Life's Essential 8, it's does the PM level itself change those specific components of Life's Essential 8, almost to frame the first aim and give us some background to be able to really figure that out. The third aim is related to what I said about older adults not always living in single family housing. So the third aim would be to measure the adaptability of a household level air quality intervention. So they have household level air quality interventions. Dr. Ethan Walker is doing one, but how can we adapt that for congregate living facilities? And I would try to figure that out using survey and interview data from employees who are working at congregate living facilities, both management and like other employees, on if we could put these filters in, what would be the barriers? What would make it easier? Would cost be a barrier? What would you need to adapt this kind of intervention to that kind of setting? So that's my tentative aims. And that is what I have. Thank you.
Great. Thanks, Rebecca. It's a really nice presentation, and it's cool to kind of see everything come together in one place here as you work on this proposal and your dissertation aims. So we'll just open it up to any questions now. Feel free to chime in on Zoom and throw something in the chat, or just unmute yourself, and happy to have a discussion here on Rebecca's presentation. And honestly, we welcome feedback too, as this is a kind of as her dissertation proposal is developing, any feedback on clarity or other ideas you have from your own experience is more than welcome.
Yeah, Karen.
I just did the actual hand raise. I couldn't find the button. That was a really good presentation, Rebecca, really clear, really interesting. I am wondering if you have thoughts, or why do you think some of the many HEPA studies haven't shown an improvement in health, like various measures of health, and why, like why your study might be a little bit different?
Yeah, I think the difference is, so the shorter ones did see an improvement in health. So I'm just speculating here because that's what scientists do. I think that as you do longer trials, there's other things that are getting in the way that make it look like it's not improving health, like incorporating in those real world factors, like people leaving their house for most of the day and then coming back, and the air filters are only in their house. Some of it might be study design too. A lot of those were on traffic related air pollution. So that's why I think it's possible we might see different results with this one. Is it's wildfire related. So it's a different type of air pollution. And so like leaving your house might not affect it as much, if that makes sense. But we might not see results.
can I just ask one follow-up? This isn't a follow-up. I'm just like a couple of things I like thought about, and Ethan and I have discussed this probably about a million times, but I wonder about that dose response. And you talked about, like, you showed that really nice figure that shows the impact on health might be more pronounced in the lower ends of PM exposure. So just with that in mind, I'm wondering if you might consider in your analysis down the road, just maybe a sensitivity analysis where you look just in that range, like look just in those people who were at that lower end of the exposure range. And then the other thing I always wonder about is other pollutants. I know PM is the one we always focus on, but like maybe there are other pollutants that the HEPA isn't getting rid of. That's it. Anyway, thanks. Great presentation.
Thank you. That's super helpful. Thank you. Yeah, Dave.
Becca, yeah, great presentation. One thing that kind of came to my mind was, how are you defining a congregate living? What was the term you used? Congregate living facility. Yeah. How are you defining that?
Yeah. So great question. And I did some of the survey already, so I have a good answer. I actually didn't define it as necessarily older adults, but looking specifically at congregate living where susceptible populations live. So the reason I did that practically is because I work at the Ronald McDonald House, and we have a back unit that has older adults, but we also have high-risk pregnancies. And I feel like that's equally important when you're looking at the adaptability is a facility like that. So it's places like skilled nursing facilities, assisted living facilities where susceptible populations would live in, also like not independently, because if it was independently like an apartment, then that's more like a household where you would have the air filter in each one. It's one where everyone's intermingled because it's like a skilled nursing facility with common areas.
Yeah, okay. That's kind of what I was wondering, is because the independent scenario can be thought of as congregate, but yeah, it's truly more of an apartment. So thanks.
Yeah, Kimber had a question. It says, can you expand any further regarding activity levels themselves and exposure? Like if you're outside and the AQI is 150, how much worse off are individuals who not only are exposed to that, but also then do bouts of intense cardiovascular activity? That's a really good question, and I don't have an answer yet. I probably will have an answer at some point, but I don't. Yeah, so I don't know the answer. Does anyone else know the answer? Okay.
Yeah, I think that's a great question that is a tough one to answer, because it depends on the activity level, it depends on the AQI level, and if you're an individual who is particularly susceptible. I guess what I typically recommend to people is if you are actively symptomatic from smoke exposure and outside exercising in it, it's probably best to not do that. If you can feel yourself wheezing, coughing, then I would tone it down. I don't think there is just a specific threshold that we can make a blanket statement for everybody. But yeah, just listen to your body. And sorry, I don't want to talk too much here. Any other questions for Rebecca, though? Yeah, Katrina.
Hi, Rebecca. That was super clear and well organized. Thank you. So I'm trying to think through myself, and so maybe you can have some insight into how looking at the Life's Essential 8 might be different from looking at individual biomarkers or outcomes like the other studies have done. And I guess the particular bit I'm thinking about is you could get more of a response if the PM 2.5 affects multiple of the pieces, or it could be sort of washed out because some of the pieces of the Essential 8, like maybe sleep or maybe exercise, might be not influenced by indoor air quality in the same way as like blood pressure might be influenced. So I wondered if that was something that you've started grappling with.
Yeah, I actually had that question today I was really thinking about that today. So it's a really good question. I think the benefit of using the Life's Essential 8 is it's matching with how the American Heart Association is categorizing cardiovascular health. So it's holistic. It's really looking at everything that could impact cardiovascular health. But if you have any suggestions, I don't actually know how to tease out sleep or diet other than looking at everything individually or just setting like a baseline for those things, because diet might impact your cardiovascular health, but it would also impact the score, and the air filter probably didn't impact your diet. So I'm still thinking through that. So I think there's pros to using it because it's holistic. It's really looking at everything, but there's also challenges.
Yeah, and that was kind of where my mind was going to, but maybe it just means you look at it for the holistic view and you also look at some of the, if you don't find anything there, then maybe you kind of turn to some of the more individual and most likely to be influenced components of it.
Thank you.
And Rebecca, I guess I had one other question, and maybe if you could just describe a little bit more about the intervention that is used in the study with the data that you're using for part of your dissertation, and maybe explain how that goes beyond just using an air filter, and how, what your hypothesis is on that intervention specifically, and why maybe versus other studies that just kind of give people an air filter. What might you see differently or expect to see differently in a study like this that kind of has a multi-component intervention to it?
Yeah. So this intervention, like Ethan said, it isn't just giving people air filters. It's air filters with recommendations on when to use it. So it actually hits on that recommendation from the paper I showed you that said that things come without recommendation. So it comes with education on when to turn it on, what level to turn it on at, that you should close your windows when it's smoky outside. So that also could change the results we see in either direction. The filter's not on all the time, but we are giving education on when to turn it on, when would be the most helpful. So that might change the health effects, in that the filter might be on more often or less often than some of these other randomized control trials. But it might be on more often than like the 1 year trial that they did. And another part of that question is like almost like buy-in to using it. Like if you had some education that using the filter would be helpful, then and how it would be helpful, then you would be more likely to use it and like really like care about using it. And so that might also change like the results that we see.
Great. Thanks, Rebecca, for explaining it. Yeah, Gil, go for it.
Hi, Rebecca. I don't think I've met you, so it's good to meet you virtually or whatever. Anyway, so I was wondering, like your third aim, you talked about using surveys and interviews. I appreciate the distinction. I'm an anthropologist, so I'm kind of more of a qualitative guy. And so I'm kind of interested how you're thinking about using interviews along with surveys and what you see as sort of the distinguishing feature between the two and how that might apply to your overall sort of research goals.
Yeah, definitely. The survey is pretty basic because I wanted people to take it. So it's short. It doesn't really give me a ton of information. I ask questions about perceptions. So how much of a problem do you think the air quality is? Do people in your facility ever complain about the air quality? And are you currently doing anything when people complain about the air quality? Like handing out masks? Do you shut the windows? Do you do stuff like that? But then I also give a picture of the filter and an air quality dashboard where you could see what the air quality is and say, if you had this, hypothetically, would you use it? What would make you not want to use it? And what would make you want to use it? But I give them options to click from. So the survey would really be expanding on that So I might get some responses that I didn't think of. So I gave them options that I would think of, like cost, or it would be too difficult to use, or on a more like employee side, I was in a nursing home and I would not have had time to turn on an air filter as a nursing assistant. So those were some barriers, but there might be barriers that I wasn't thinking of. So the point of the interview would be to get some insight on things that I wouldn't have thought of. And then I don't know 100% what I would do with that, but it's possible to go back in and add those to the survey and do that again, like almost like informing the survey again. So yeah. Also, if you have any suggestions, I'm not super qualitative, so I have some something to learn from that.
Oh, I've got tons of suggestions. You're probably going to regret that you said that, honestly, but no, I'm just kidding. But okay, so that's interesting. And then I was wondering, another thing you pointed out that I found really interesting is that there seems to be like a in terms of what you're saying about some of the existing literature, some limitations regarding behaviors and what people are doing, actually doing. And so I'm wondering if you thought about like ways you might move that literature forward in your own research in terms of actually trying to document and understand specific behaviors and you know people's like decision making, whether they engage in a behavior or not. um, I mean, observations probably aren't practical, but there are other methodologies that you might think about that might help you sort of speak to those sorts of issues.
Yeah, yeah. I'm probably going to email you after this. Those are really good suggestions. Thank you.
Sounds good.
Hi, Rebecca. I have a quick question for you, and great job on your presentation. Is your dissertation work, is it just focus on smoke season, or are you also looking at winter, high PM levels?
Mm-hmm. The intervention was over smoke season and over the winter. So both. In part because fires are unpredictable and it would be really difficult to just do a study in those wildfire months, and also unethical to hope that those would be really bad wildfire smoke months. So I could see results. So it's the whole year, which yeah, but yeah, that's the answer.
And is this taking advantage of like the purple airs
Yeah.
that the homes currently have purple airs, or are you gonna have to recruit the cohort?
Yeah, so for the first two aims, I'm working with some of the data from Ethan's intervention study that we've been doing. So I've been helping on the back end for like the last year and a half. So I'm taking advantage of that data, which had two PM sensors. One that actually changed color when the air quality changed, the Zens, and then one just classic PM sensor. So yeah.
All right, sounds like a cool study.
Yeah, and thanks again, Rebecca, for the nice presentation. And we'll hear, I'm sure, next in the next semester too. And Rebecca does her second presentation for the program. Just a little bit more details about the study that she's working on, and hopefully some preliminary results as well. So, unless there are other questions, I think we can wrap it up for today. But thanks again, Rebecca, and thanks everyone for the questions. And I think there have been some great conversations, some great ideas. Food for thought on as we move forward for this on this. So thanks.
Yeah, thank you. My mom's here, so hi. Thanks for coming.